been asked by the organizers to give an overview of all the main issues and priorities in Europe at the moment regarding communicable diseases. This is the wrong presentation. I will divide the presentation into two parts. First part, I will talk about the threats that are, if I can get the slides working, the immediate threats that we are facing at the moment. And you know already some of these have been mentioned this morning. And then I will look at the more long-term priorities. What my aim to do is to give you the evidence behind many of the points that the Commissioner made this morning, why we are worried about certain things. So we go for the threats. This is one of the reasons our agency was set up, in fact, because there was some of you may remember the SARS outbreak, 2003, that actually brought international travel almost to a standstill. We have a new SARS, I don't know if you realize that, I'll come back to that. And also there was the threat of this influenza pandemic. Everyone's talking about an influenza pandemic. And of course, we had an influenza pandemic quite recently as well. We were lucky. This is what the influenza pandemic looked like. The black arrow is the start of the pandemic. We were lucky that this pandemic was actually quite mild when you compare with other pandemics. What I don't think many of you realize, that just because we had one recently does not mean that next year we do not get a new pandemic. Because the influenza virus, for those of you who know viruses, is one of the most manipulative viruses. It's all the time changing, shifting, drifting, slight mutation, every year. And I would not be surprised if next year we get a pandemic which is much worse than the one we had. And even though it was a mild pandemic, a lot of people died. These are the mortality that we collected. We know this is an underestimate, because only people that were recognized to have died from influenza are in this system. A lot of people die from complications of influenza, and they're not in the system. Okay, so one threat we are all the time looking at is influenza pandemic. You all remember last year images of Ebola in all the television stations, news. Why did Ebola suddenly become a global problem? Well, Ebola has been around for decades. And what happened this time is that normally Ebola lived or caused problems in small villages, remote villages in Africa. Suddenly, the virus got into a capital, one capital in Africa, and it became a global emergency because it spreads so quickly in densely populated areas. It created a huge amount of work for everyone. Even though in Europe we did not even have one transmitted Ebola case. We had imported cases. And of course our agency we devoted all our resources to this. It was a top-level threat, caused a lot of work. And I mentioned SARS. Well, we have another SARS, another coronavirus, very similar to SARS, not perhaps as lethal, but still kills people. The Middle East version of SARS, the MERS. And I don't know if you realize, but this is still going on. This epidemic in Saudi and surrounding countries is still going on. We know a bit more about it now. We know that the virus likes to live in camels where it doesn't cause disease, but we don't know the full picture. And it's still being transmitted. And you can see we had to track all the imported cases. We had a big surveillance system going on at the beginning when we weren't sure. And the reason for our agency doing this is that we didn't want this to happen. This is what happened when one case went back to South Korea and infected the healthcare system there and created an outbreak in South Korea of this coronavirus with a lot of bad consequences. We were lucky this did not happen in the European Union. Lucky, and a lot of effort by a lot of governments, a lot of public health people were involved, and of course our colleagues at WHO. The one we're talking about now, Zika. Well, again, Zika was a virus that lived in some very remote areas in Africa. Never caused problems beyond that, as long as it lived in Africa. Because the herd immunity there, you get immunity to this virus and then it doesn't cause you much problems. Suddenly, it went over to South America and to some Asian countries. You can see in the graph the number of countries and territories reporting Zika cases. You can see how quickly it rose. And the Zika needs a particular mosquito, and just because they had the mosquito, it managed to infiltrate most of South America and Central America. This is the situation at the moment. Zika has not gone away, not by a long shot. It's growing and still growing fast. And one thing that we are all a bit worried about, the Olympic Games in Brazil. Some people think that Zika went to Brazil during the World Cup in Brazil 2 years ago. That was when a mosquito hitchhiked on an aeroplane. It's possible, we don't know. But the Olympic Games will bring a lot of young people there, and we're expecting quite a few to come back with the virus. And talking about mosquitoes, we've been tracking the changes that the climate has made to the mosquito populations in Europe. Why? Because the Aegyptus aedes mosquito is the one that gives yellow fever, that carries yellow fever. It also carries other viruses, but that's the one we're most worried about, because at the moment there's a massive outbreak of yellow fever in Angola, and now we believe it's moved into Congo and Brazzaville, which is a very populated, I think it's 10 million capital, and there it's going to spread really fast as well. And this is going to cause another problem. So I'm giving you an anticipation on yellow fever. So we're tracking the mosquitoes in Europe that can carry yellow fever and dengue and chikungunya. These are all related viruses that can cause problems. And unfortunately, I pushed the one on the left, Albopictus. This is a tiger mosquito. It gives a really nasty bite. This was almost unknown in Europe about 50 years ago. Now it's taken over the whole of the south and is growing and is moving north because the environment, the climate has changed to make it easier for this mosquito to live, survive, and thrive. One virus that we are always worried about in Europe, very similar to the ones we're talking about, also carried by mosquito, a different mosquito, but is West Nile. And I believe you probably all know about West Nile in Europe. What you don't know is that we've been tracking where West Nile is hitting, and it seems to be growing. The area of infected mosquitoes for West Nile virus is growing in Europe. Okay, so now that I've scared you with a few threats that we are tracking, I'll go to the more important problems, which are the long-term problems, which need much more investment than a quick outbreak solution. I'll start with one you're all familiar with, tuberculosis. 5,000 infections every month, new infections diagnosed. That's where we are in Europe, in the EU at the moment, 5,000. We believe there are more, and we are missing them. That's quite a lot. And of course, it's not evenly spread. It is selective in some countries. It's higher in some countries than in others, the ones in red over here. The overall situation, if you look at the trend, it seems to be getting better because there's better health systems, so you get more screening and more treatment, but only slightly better. And we are nowhere near the target for eliminating tuberculosis that we talked about 10 years ago. The area we are worried about at ECDC is the multi-drug resistant tuberculosis. This is not getting better. And of course, again, the multi-drug resistant tuberculosis is more frequent in certain countries, and they need to do more to be careful about this strain of TB. And why are we worried about it? Well, because the treatment success rate, in other words, if you use the right antibiotics, you should get a cure. Well, for multi-drug resistant, even if you use the right antibiotics, the second line antibiotics, and the third line, you still may not get a cure. And the overall for Europe, it's one of the targets for the elimination of tuberculosis. The overall target is 70% cure of all the multi-drug resistant TB. We're not there, and only few countries are there. And of course, within that group of multi-drug resistant, there is the extensively drug resistant, the ones that all the normal antibiotics don't work on. And again, this is something we are very worried about. Every sixth multi-drug resistant is an extensively drug resistant tuberculosis. Again, we are seeing it more in some countries. And of course, the outcome of this is is often death. That's the outcome, not cure. You may know that in Europe we have a target to eliminate tuberculosis, and we have some indicators. These are the indicators that we are tracking, and we are very far away from eliminating tuberculosis. So although many people think it's a disease of the past, a disease of the turn of 2 centuries ago, this is very much still alive with us and still causing problems. I move to one that was mentioned several times, the influenza. This is our last season of influenza, in other words, the one that just finished a few weeks ago. It saw the return of the pandemic strain in the EU. We thought it went away, but the pandemic strain was the main strain of a virus that attacked us this last winter. And you can see the difference here. In black is the pandemic strain. The year before is on top. The year before was a different strain. Actually, there was a mix of A's, but not the pandemic strain, very few pandemic strains. And the one below is this year's strains, and it was a return of the pandemic strain. We're not sure what's going to happen in the next season. We do know there will be a season, and we're a little bit concerned about matching the virus to the vaccine. We're lucky that the pandemic strain does not kill as much as the other strains, and this is tracking the deaths amongst elderly. And you can see the H3N2 strain, which is the strain of 2 seasons ago, that actually kills much more than the pandemic strain. And again, the commissioner was very right to mention this. We have a target for vaccinating the elderly and protecting them against these viruses. The target is 75% of all people over, I believe, 65. No one has reached that target except one country. No one, just the Netherlands. What you're seeing there, Northern Ireland, Scotland, England, and Wales, that's because of the way we collect our data. If you put them all together, they do not reach the target. Everyone else is very far from that target. One of the reasons is the doubts about the vaccine. We don't want to hide this. We are tracking the vaccine. We have a special project that looks at the efficacy or tries to estimate the efficacy. How well were the strains we've put in the vaccine this year matched against the strains that actually attacked people? And you can see that in some cases we get about 54%, and in some strains it's actually really poorly matched, because by the time the vaccine has been manufactured, that A3N2 strain has changed almost completely. And this is the problem with influenza. The virus keeps changing. Another reason which hit influenza quite badly, and this is very unfortunate, is the complications of the pandemics. This is the vaccine that was used for the pandemic. And you've all heard about narcolepsy. I'll show you what narcolepsy is a condition, a brain condition of children mainly, but not also teenagers. And it's very difficult to treat, and it's can be quite nasty. And this is the narcolepsy rates, if you like, before the pandemic, and then you can see in the circle what happened when they started using this Pandemrix, which was a very good vaccine. It protected really well against the pandemic strain, but it had this side effect. And we've together with quite a lot of researchers and WHO, we've looked into the countries most affected, and there's no doubt that the vaccine side effect caused narcolepsy. Okay, so that's influenza. You see, I'm giving the main issues. I can't give you all the issues in communicable diseases. But let's talk about sex. That usually wakes people up in the morning. HIV, again, mentioned before by previous speakers. If you look at AIDS, that is when people start to feel the symptoms of the broken down immune system, that's getting better. And the line, that's a log graph, so you don't see just how steep the AIDS is getting better. I'll show you with this. This is the real numbers. It's improving. And I think if we carry on as we are doing now, giving the antivirals almost straight away, as soon as we find someone with HIV, AIDS will go away long before 2030, which is the target the United Nations have set. Long before 2030 in Europe. But HIV, it doesn't look like it's going away, does it? These are new cases every year of HIV that you're seeing there. And if you look a bit more carefully at that green line and you go into the data, you will see what's going on. HIV amongst heterosexual women, getting better. Amongst heterosexual men, getting better. Amongst injecting drug use, low, because a lot of people now recognize you must give needles, you must give oral substitution therapy. And it works. So it's low in Europe and getting better. Where we are failing in HIV is among men who have sex with men. And this is a theme I'll come back to for other infections. There seems to be something going on in this vulnerable population that we are not, our prevention programs are not managing to affect. I told you that syringes work. Give syringes to injecting drug users and you keep the rate of infection down. We have some targets on syringes set up by our sister agency, the EMCDDA, that looks only at drugs. And they say, if you have a drug user who's using consistently, you need to plan 200 needles a year, minimum. And this is the situation in Europe. Only the countries in green are managing to give out that amount of needles. So there still is more to be done for injecting drug users. But it's men who have sex with men that we consider the main priority. And not just for HIV. So if you look at what's happening with gonorrhea, for example, and with lymphogranuloma venereum, it's a specific strain of chlamydia, and also in syphilis, they are all rising in men who have sex with men. So there is this massive multi-epidemic going on that's sexually transmitted in this group. We must do more, or this is going to get worse and worse. We try and raise attention to this. If you look at where it's growing fastest in Eastern Europe, where men who have sex with men traditionally hid their sexuality, and now they are becoming more confident to come out. And being part of that coming out is exposing them to more infections. And we are trying to raise this awareness. HIV, again, is a problem, especially in this risk group. We cannot just sit back and ignore it. And one of the reasons, it's not the only reason, one of the reasons is condom use. In the 80s and the early 90s, everyone was talking about condoms to save your life against HIV, and people used them. Then the treatments came out, people stopped dying of AIDS, people stopped using condoms. And that is certainly the case with men who have sex with men. Not only, of course. It's not the only reason. But it's something I think most of us have begun to forget, that we need to promote condoms as part of our duties in public health. If you look at what's happening in the bacterial infectious diseases, chlamydia, it's not on there because it would be so big, the others would be dwarfed. Huge amount of chlamydia in the EU at the moment, huge. And again, this is an underestimate. This is the result of screening women. We don't screen men for chlamydia. And of course, women get it from somewhere. So there's much more chlamydia than the numbers we have in our database. Gonorrhea, again, very high. Syphilis, almost as much as HIV. And if you look at the trends, like gonorrhea was getting better. Again, you can see the outbreak in men, especially, but also in women. And if you look at who they are, you see the women are also increasing, but the men who have sex with men is where the epidemic is. Why are we interested in gonorrhea? It's an easy to treat bacterial because it will not remain easy to treat. We are tracking through one of our projects the antimicrobial resistant gonorrhea. Gonorrhea has a particular feature that it can resist certain antibiotics, especially the penicillinases. And we were getting a bit nervous around 2007, and they changed the recommended antibiotics then, and that's getting a bit better. But look at the one where there's M and F, the red line. That is azithromycin. It's one of the more powerful antibiotics. On this graph, it doesn't seem like there's a major problem. But if you look at the last few years in more detail, this is what you will see. This is looking at men and women, azithromycin resistance. So in women, it's getting better. They take their antibiotics how they're supposed to. Men don't listen so much, and this is the result. And again, it's heterosexual men, but also men who have sex with men, where the resistant strains are becoming more common, and they are becoming transmitted. So your first infection will be with a resistant strain. You don't know that because your doctor would say, oh, gonorrhea, he will give you the normal antibiotic, and that will not work, and then your resistant strain becomes even more resistant. So this is something that will get worse unless we do more about it. And then there's, of course, the combination of HIV and gonorrhea, and we are seeing more and more of this. There's also the combination of HIV and syphilis. Again, we're seeing more and more co-infection. One makes it easier to get the other. Okay, I'll move to the liver now. You are all aware there's a big awareness about hepatitis. I'll start with hepatitis B because that's the easier one. That's the one that we have a good vaccine for, and you vaccinate everyone and it goes away. And the trends, if you look at the trend of the acute cases, in other words, new cases, that is definitely going down. But if you look at the trend for those who have had the virus for a long time, that's not going down. And the reason is because the treatment for those already infected is not so good for hepatitis B. And who are these? How are they getting it? Sorry. It's mainly heterosexual transmission. It's a sexually transmitted disease. There are some problems in some small clinics and some small hospitals or hostels. You get some transmission there still in some parts of Europe, but it's mainly a sexually transmitted disease. The mother-to-child transmission line you see there, those are imported cases. Those are refugees and migrants mainly who come with the infection. Yeah, I'll just move to hepatitis C. Hepatitis C is the one that's in all the newspapers, of course, because of the treatment. That is, as the commissioner mentioned, is extremely expensive, but is also extremely useful. It works really well. Our problem with hepatitis C is because it is asymptomatic. It shows itself in the new infection so rarely. Our data is really poor on hepatitis C. And who is getting hepatitis C? It's still the injecting drug users. And again, in some small clinics, you get some transmission. If we go to the foodborne infections, There are some priorities here as well. I'm going to focus on the local infections, the EU, because we import a lot of food, and it's not fair to talk about the infections that come from where we import outside the EU and within the EU. Campylobacter, that's the one that still causes the most problems by far. And coming second is Salmonella. Again, you don't hear so much about Salmonella. In the 80s, everyone was talking about Salmonella and eggs and raw eggs and children. You hardly hear anyone talking about Salmonella. It's still a problem, and a big problem in the EU. It still causes outbreaks. If you look at the other infections, if you zoom in on them a bit, they are nowhere near as major as the Campylobacter and Salmonella. But some of them, like Listeria, kill a lot more than Campylobacter and Salmonella. This is a tracking of the outbreaks caused by these diseases. So at least 45,000 people in 1 year are affected by the outbreaks of foodborne diseases in the EU every year. And of course, it doesn't kill so much, but it does cause problems. And many of them have to go to hospital. And again, the problem with the data, especially for foodborne disease, is that a lot of people get diarrhea from an infection. Very few of those actually go to a doctor. Usually you take some medication at home. You go to a doctor, and very few of those that go to the doctor actually get a sample sent to the lab. And those are the ones that we have data on. Everyone else, we have no data on them. And if you look at the case fatality, you can see here, if you go down to the Listeria, you see it is the one that kills the most by far. It's quite evenly spread, Campylobacter, across the EU. Some countries have more of a problem than others. In the north, it's more travel associated, so the tourists who go to the Mediterranean, for example. And Campylobacter is not going away. It's actually getting worse, despite all the investment in food safety, HACCP, and the EFSA, and all the agencies we have working on this. It's actually getting worse. And again, another reason why we're worried about Campylobacter is that it is developing resistance to the normal antibiotics. Normally, you would not treat Campylobacter with antibiotics if it's a mild case. But the more severe cases will need antibiotics, and there is signs of resistance. Somebody did a study to estimate of the Salmonella cases that we have reports on, how much Salmonella is there really in the community. And this is a graph of their findings. You see the icebergs below the water, how much bigger than they are than the tip of the iceberg. Salmonella is one of those where most of the infections by far are missed by our data collection systems. And again, Salmonella is quite common throughout Europe. Some countries have more than others. And again, in Salmonella, there is resistance developing. The one I most worry about, and my colleagues agree with me, is Listeria. Listeria, when I was a medical student, Listeria was a novelty, something, eat certain cheese, you get Listeria, it's okay, it will pass. This is getting much worse. It's becoming a mainstream foodborne infection. And the reason is because there's such a lot of movement of food now. So frozen foods or frozen cheeses and hams, before they would stay in the area where they are produced, now they move around several countries before they are eaten. And that is increasing the number of cases from Listeria. And Listeria is bad mainly because it affects the old and the very young. And of course, the old and the very young are the ones most likely to get complications or die. And you saw the risk ratio, 15% to die if you get Listeria, if you're in those age groups. Another one my colleagues are tracking, hepatitis A. It's lower than most, but still something to worry about, because not so long ago, there was this huge outbreak of hepatitis A in Europe. And this was caused by frozen berries, and we think the ice was contaminated with hepatitis A, but we have no evidence of that. All the tests have come out negative. And this caused a lot of problems, a multi-country outbreak, especially in Italy, but also in other countries. So even something as simple, if you like, as hepatitis A, with a good vaccine, easy to diagnose, can cause outbreaks in this day and age. I'll move to the one perhaps that you most are aware is a major problem, and that's antimicrobial resistant pathogens, other pathogens. So the gram-positive bacteria were the first ones we were worried about. You all remember methicillin-resistant Staph aureus, MRSA. This 15, 20 years ago, a lot of attention. There were outbreaks of wound infections after operations, and it was well studied, and there are solutions for this. And you can see the line, the brown line on the right, it's going down, because there are solutions for methicillin-resistant Staph aureus. Most of the gram-positives are under control. Not so for the gram-negatives. If you go to the other side, we are really doing badly, in fact, with the gram-negatives. And the Klebsiella, Pseudomonas, there's a whole list, E. coli. We're really doing badly. They are becoming more and more resistant. They are following Darwin's law that they will develop the necessary environmental resistance against the threats and become stronger each generation. And each generation is becoming more resistant to the normal antibiotics we use. If you look at Staph aureus, this is the only success we can really be proud of. It's come down in most countries. We know what to do, and we're quite happy with that. But if you look at the gram-negative Klebsiella, then it's rising almost throughout the EU, the resistant strains. And, well, there are others. I won't oversell this. But if you look at the situation, for example, of the CPE a couple of years ago, it was a problem in 1 or 2 states. If you look at the same thing now, this is how quickly it becomes a problem in other states, the same bacterium. We've invested a lot into this area. If you go to our website, there's a huge amount of material you're welcome to use. Of course, we work closely with our colleagues in WHO on this, who also believe it's a major problem. And these are just some shots. One thing we are very happy that is growing is the Antibiotic Awareness Day. Please do try and support it. It does raise awareness amongst general practitioners, but mostly among especially young mothers who insist on antibiotics for their children when they don't need them, but also others who think antibiotics will cure everything. Another area we're concerned about are the infections you get when you go into a healthcare institution. We did a survey in 2012-13 to try and find out on any one day how many people are suffering from an infection they got from the hospital, not brought into the hospital. And this is what we call the point prevalence survey. And to summarize the results, it's quite an extensive survey. More than 1,000 hospitals in the European Union. A lot of people trained, because we have to make sure that what is reported in one hospital in, for example, Riga, is the same. They're using the same criteria as what's reported in the hospital in Lisbon. And this is not something that's easy, believe me. But we invested a lot, and we came to the conclusion from the results, on any particular day, there are about 6% of people in any hospital are there because they got infected in the hospital. And if you look at the global figures, the acute infections are in the blue, about 3.2 million per year healthcare-associated infections. If you go to the long-term care facilities, for the elderly and the disabled and so on, the asylums, there's even more, of course, because they have less facilities to prevent this, 4.3. So this is every year the kind of infection rate we are seeing. And these are all preventable infections, all of them. And they all have a strong economic impact because they keep the patients longer in hospital, away from work, and taking various treatments. Okay, so I just want to skip that. Again, we invested a lot in this area. There's a lot of material on our website if you're interested. The final one I'll come to is the one our commissioner started with, and that's the vaccine preventable diseases. And I just want to start with introducing Max to you. Max was a healthy young boy. He liked his hockey. I think you played that a bit over here. Max, like many of his classmates, had never seen a case of measles in their life. The mothers were saying, I don't want to inject him with mercury. This is what they say about the measles vaccine. So most of the mothers in his class refused the vaccine, the measles vaccine, because they'd never saw measles. When he became a teenager, Max got measles, and he got what's called subacute sclerosing panencephalitis. It's a type of brain inflammation, which is a side effect or a complication of measles. And it's quite well recognized. In other words, it happens regularly. He died 2 years later. He was absolutely healthy otherwise. So it's a war for measles. It's literally a war to try and fight the rumors with fact. And we need your help on this because it's a long war that we have to keep on fighting. The World Health Organization has even set targets for measles elimination. And the first target was by year 2010, there will be less than 1 per 100,000 in any country in Europe. And there was some work to try and reduce some of the myths about the vaccine. But let me show you a bit about what happened. So when they issued this target, 2001, there were just a few countries that looked like they were not going to make it. The light green and the green are the countries that are already managed to get that figure. So 2001, 2002, 2003, it seems to be getting better. And then what happens? It gets worse. Because when you start to see less of an infection, no offense, but the politicians say, oh, we don't need to invest so much. We have other priorities. Of course they have other priorities. But when you take your foot off the accelerator, the car stops. It doesn't keep on going. And this is what happened with measles. So we are nowhere near eliminating measles. In fact, we are worse than when we set the first target. And if you look at today, the situation today, the green country color are those countries that have achieved the high levels of vaccination you need, which is 95% plus. So some countries have achieved that. And the red dots are where measles is still causing outbreaks. And you can see that most countries in the EU have these outbreaks. And like I said, there's this word that we are using now called hesitancy. If you follow the yellow line, the less you see of an infection, the more chance that people will say, but I don't want to vaccinate my child because we don't see this anymore. It's more risky with the vaccine. And this is causing what we call hesitancy. And this is causing what we call deaths that are totally avoidable, like Max, who was a perfectly healthy kid. And again, we've invested a lot in trying to understand this hesitancy. but we are nowhere near having the answer. Okay, so I've come to the end of my big overview. I only touched on some of the major issues as we see them. Of course, I didn't mention all of them, and I'm sure we will have discussions later on in the day about these. If I can summarize, there will be another influenza pandemic. I guarantee you. You have a guarantee from the ECDC. There will be another influenza pandemic. When? I cannot guarantee. Will it be worse than the last one? Probably. Probably. There are threats. A year ago, nobody even knew what Zika was. The year before that, Ebola was something for the textbooks of medical students. What's going to be the Zika of next year? We don't know. We hope it's not dengue, as happened to the United States. There are the major communicable diseases like TB, hepatitis, HIV. They are still major diseases, and they're major for a reason. The evidence shows this. The vaccine hesitancy is the war we really, really all have to pitch in, because it's getting worse. And antimicrobial resistance, you saw in almost every one of the major issues I mentioned, there is this growing threat. And this can be fixed if the medical profession pulls together and follows the guidelines accordingly. But that's, of course, is quite difficult. Thank you very much.